Good morning, everybody. Thanks for showing up after Docs at Rock. A few bleary-eyed people, maybe a bit deaf and hoarse. Again, my name is Eric Clark, Chair of the CPD Committee. Great to see everyone here and yet another wonderful breakfast symposium today. I'm going to hand things over to Rahim Vahani, who's going to be our moderator for what I think is going to be a really interesting, useful, practical talk from a great panel of speakers that we have here.
Thank you. Thank you very much, Eric, and welcome everyone this morning. Please help yourself to some breakfast, grab a seat, and we'll get started. My name is Rahim Vahani. I'm an emergency physician working at Brampton Civic Hospital in Toronto, at the St. Joe's Hospital. I'm an associate professor of medicine at the University of Toronto. And on behalf of CAPE, the Canadian Association of Emergency Physicians, I'm delighted to be the moderator for what I think is going to be an amazing session this morning on sickle cell disease. Our symposium topic was independently chosen by the Conference Scientific Committee. This program received financial support from Vertex in the form of an educational grant. All efforts were made to mitigate any potential biases for this, and the faculty have declared all the potential conflicts of interest, which are displayed over here. In terms of mitigating potential biases, again, as I mentioned, we made sure that there was no industry involvement in the planning of the content as well. Management of sickle cell disease is a challenge, especially when you get into smaller cities and smaller towns. A lot of the people who have sickle cell disease tend to conglomerate around larger centers. But when these patients are seen at smaller sites, it becomes a challenge because there might not be enough volume there to understand the pathophysiology around it or the acute management of these patients. And sometimes you tend to miss, some very serious complications of these diseases. Our learning objectives, therefore, are to appreciate the experience of a patient with sickle cell disease presenting to the emergency department. It's to develop an up-to-date approach to fever and a pain crisis, which are the most common reasons that they present to the emergency department. It's to identify and treat a chest crisis, and finally learn life-threatening complications of sickle cell disease as well. Now, to increase the interactivity of this presentation, what I would ask you to do is if you can get your phones onto slido.com or use the QR code over here, and the code number is 2373032. The purpose of this is to allow interactivity because we'll be asking questions that you can actually that will be polling through the session, that we can actually see the live audience response. We also encourage you to use the chat feature of this, which then allows us to take the questions that we can relay through at the end of the presentation. Okay, so let's get to the first poll. And what we'd like to do is gauge how well or how comfortable you are in dealing with sickle cell patients. So, have you ever treated a patient with sickle cell disease? Answer A, no, never. Yes, but infrequently. Or C, yes, and regularly. So if I can ask you to use that Slido link that you can go with, and I'll put it back up again, because there'll be other questions as well throughout the presentation that you can use from that. While you're filling out this, allow me to introduce you to the presenters. This is great. Yes, but infrequently, no, never, and yes, regularly. Beautiful.
Good to know.
Okay. While this poll is setting up, allow me to introduce you to our speakers for this morning. The first gentleman I'd like to introduce is Dr. Dominic Shelton, who's an emergency physician at Sunnybrook Health Sciences Center and an associate professor at the University of Toronto. He co-founded Camp Jumoke, which is a camp for children with sickle cell anemia, and he's also the camp's former medical director. In addition, he was also a member of the sickle cell panel that developed the Ontario Ministry of Health Clinical Handbook for Sickle Cell Disease Vaso-Occlusive Crisis. The second speaker we'll have this morning is Ms. Biba Tinga, and she's the mother of 4, of whom is a young adult living with sickle cell disease. She will share with us first experiences, and so she has a unique understanding of the needs of children and families with sickle cell disease. For more than 15 years, she has leveraged her experience in research for new drugs, the risks associated with hospitalizations, and efforts to implement genetic testing to advocate this in Canada and globally. She is currently the President and Executive Director of Sickle Cell Disease Association of Canada, the Canadian National Umbrella for Sickle Cell Organizations, and sits on the Board of Directors for GASDCO, the Global Alliance for Sickle Cell Disease Organizations, and on the board of the Network of Rare Blood Disease Disorders. The third presenter is Dr. Madeleine Verostek. She's an associate professor at McMaster University and serves as the director of the Adult Hemoglobinopathy Program. She has worked to establish sickle cell disease guidelines in the American Society of Hematology, the European Rare Best Disease Practice Group, and the Canadian Hemoglobinopathy Association, as well as the Ontario Minister of Health, including the recently launched Ontario Health Sickle Cell Quality Standards. At this point, we'll go through the poll quickly here. It seems that a lot of people deal with sickle cell, yes, but infrequently. So hopefully this is going to be an amazing presentation for everybody to take home a lot of messages and key learning points. At this point, I'll hand over to Dr. Dominic Shelton, who will begin the presentation. Thank you.
Good morning, everyone. So let's get right into the cases. So the first case that I'd like to present to you today is that of a 28-year-old male with sickle cell disease who presents with pain in his limbs and back. So the story is that he's had a 2-day history of severe pain in his bilateral legs, arms, and lower back, and he states that this feels like his previous sickle cell pain. So that's an important historical point for any patient with sickle cell that presents with pain. You want to know if this is something that feels like their usual experience of pain, so as to start to guide your differential in terms of narrowing it down. The patient also states that there's been no improvement with analgesia at home. And you want to dig deeper into the specifics of exactly what the patient has been taking, because that will determine what you give the patient in the emergency department with regards to analgesia. So the patient says that he's been taking morphine 5 milligram, about 4 doses over the last 24 hours. There's been no history of fever, and on physical exam, his vital signs are all stable, and the physical exam itself is normal. So what do you think the likely diagnosis is here? So I'm sure that most of you, who have at least had exposure to seeing sickle cell patients in the past will realize that we're dealing likely with vaso-occlusive crisis. So this is the most common reason as to why patients with sickle cell present to the emergency department. And the underlying reason for this is, as the name states, vaso-occlusive crisis, that being occlusion of the blood vessels causing ischemia to tissues. And it's also been found that there's a significant inflammatory response that occurs because of this occlusion causing the pain. It's important for you to realize that most patients with vaso-occlusive crisis manage their painful crises at home. So what we're seeing in the emergency department is really the tip of the iceberg. And it's a reflection of how severe the pain is, the fact that they need to come to the emergency department to manage their pain, and that they're not able to manage at home with their usual modalities. Common sites that are involved in vaso-occlusive crises are the lower back, limbs, and ribs. And some triggers are infection or dehydration or extremes of temperature. But it's not uncommon that there is no identifiable trigger to incite the crisis event. So I have a poll question for you. And that is, which of the following analgesia orders would you write initially for this patient? So to go through with them, morphine 5 milligrams IV, Q 30 minutes PRN, or morphine 10 milligrams IV, a dose of ketorolac, hydromorphone 1 milligram IV, or hydromorph 2 milligrams IV, or hydromorph 2 milligrams orally. So if I can give you a few seconds to vote here. And so just to let you know, there is no one right answer, but we'll discuss what the best answer is here. So can we show the polling? next slide, and then it will. Okay. Everyone's answered there? Okay. So about a third has said hydromorph 2 milligrams IV, about a quarter morphine 5 milligrams IV, 19% hydromorph 1 milligram, and 12% morphine 10 milligrams IV, and some would give ketorolac, and some, about, I think that's 5%, would give hydromorph 2 milligrams orally. So this is interesting. There's a real wide distribution of responses here. So, you know, when it comes to patients with sickle cell, we tend to divide them into, when it comes to deciding about analgesia orders, we divide them into two camps, and that is, are we dealing with opioid naive or opioid tolerant patients? And the mere fact that this patient has been taking the dosing of morphine as stated, this is an opioid tolerant patient, and therefore would need a higher dose of an opioid in the emergency department. And so really we're looking at the need for either morphine 10 milligrams IV or the equivalent of hydromorph 2 milligrams IV. I think a dose of morphine 5 or hydromorph 1 is likely going to be under treating this patient's pain. And I think that's something for you to just be aware of, right, in terms of the fact that they are opioid tolerant and therefore need higher dosing. Ketorolac, you know, has a role for treating crisis pain, but not in isolation. It really should be used as an adjunct. Again, when the pain is that severe that they need to come to the emergency department, they're going to need more than an anti-inflammatory to get their pain under control. And hydromorph orally, you know, is not a wrong answer, has a role in terms of giving an opioid orally. But again, they've been taking oral medications at home. And so in coming to the emergency department, the majority of them need parenteral dosing of opioid. But sometimes it will have a role, particularly in a patient that you're unable to establish an IV in. So just to re-emphasize some of the points that I've made here, so there are some emergency departments that actually have order sets for patients that present to the emergency department with patients with sickle cell that present. And as part of the order set, there are analgesia orders. And this is an example that I'm briefly going to show you here of the order set that's used at University Health Network here in Toronto. And the analgesia orders are divided into two, for opioid-naive patients and opioid-tolerant patients. And so here we see the orders for opioid-naive, and it's further subdivided into two in terms of the initial orders for pain control and then the orders for ongoing pain control. And so the initial for opioid-naive would be the morphine 5 milligrams IV or sub-Q, or the equivalent hydromorph 1 IV. And then for, or oral dosing of the higher dose of morphine or hydromorph. And then the equivalent dosing for ongoing pain control, but just spacing the dosing interval out further. And here we see for opioid-tolerant patients, again, the higher dosing that's required. So morphine 10 milligrams, IV or sub-Q, or hydromorph 2 milligrams, IV or sub-Q, and again, the corresponding dosing for either oral or ongoing pain control. So a point that I want to emphasize here is the need for early initiation of analgesia for patients with vaso-occlusive crises. And this is supported in the literature. There are guidelines that have been established by several official bodies. And here's an example of one put out by the Ontario Health, their quality standards, that recommends that analgesia should be started within 30 minutes of triage or 60 minutes of emerged presentation. And another body, the National Heart, Lung, and Blood Institute, which is a US-based organization, similarly recommends administration of analgesia within 1 hour. Now, I know that many of you are probably thinking this is wishful thinking, just given the constraints that we deal with in the emergency department, but I do feel that this is a goal that we need to aim towards. And you know, there are a few reasons for it. I mean, first of all, just from a humane standpoint, I mean, people with a disease that causes severe pain should be treated with appropriate analgesia in a timely manner. There's also evidence to show that there is decreased rates of admission to hospital with early administration of analgesia. And evidence, and there's another very tangible benefit, and that is decreasing the rates of complications. And there's a specific complication that I'm going to refer to in the next case, that it can decrease the progression to this complication. So overall management of vaso-occlusive crises, the emphasis being on opioid analgesia, but also there is a role for oxygen and IV hydration. But let me put this into context. You know, years ago, we used to routinely put all sickle cell patients that come in with crisis pain on supplemental oxygen and bolus them with IV fluids. And that is not done anymore. So there's evidence to actually show that it potentially could be harmful of both the supplemental oxygen and IV hydration when it is not required. And so it really now is limited to just patients who are hypoxic or volume depleted. So like all patients in the emerge, we have to decide, you know, is this someone that can be managed as an outpatient, or do they need to come in for further management? And so some of the factors to take into consideration would be, are there any concerns about any other complications of their sickle cell disease? How well have we been able to get their pain under control? And these are patients with a chronic illness. They know their disease well, and so it would be very reasonable to ask them, you know, when your pain is at this point, and based on your previous experience, what's usually done? Is this something that you can go home and manage the pain, or do you usually need to be admitted to hospital? And then, of course, whether there's appropriate follow-up, either with their primary care physician or their hematologist. And lastly, just a few points here to raise for us to be aware of our biases. We're living in an era of an opioid epidemic, and we're dealing with a patient population that has a disease that causes severe pain, that requires opioids and high doses of opioids sometimes. And sometimes we have these patients who actually tell us what they want and what they need in terms of their opioids, and sometimes even specifically the amount. And let's face it, our antennas go up. These are patients that, you know, we start to be concerned about potential drug-seeking behavior. I think it's important to realize that patients with sickle cell disease are not driving the opioid crisis. And that's actually bared out in evidence to show that a small percentage of patients, around 5% of patients, evidence shows, use opioids for reasons other than controlling their pain. We need to also dispel the myth of normal vital signs, therefore they can't be in pain. That is a fallacy, and we, sometimes hear this from our colleagues that they're, they have normal vital signs, and therefore they're unlikely to be in severe pain. The other thing that I think is important for you to realize is that, from an early age, patients with sickle cell are taught how to manage, how to cope with their pain, using pharmacologic means and also non-pharmacologic means. And part of the non-pharmacological means is, strategies like distraction. So for you to see a patient with sickle cell who is in the emergency department and in pain, that is their complaint, but they're on the phone, whether speaking on the phone or texting on the phone, that is part of their coping strategy. And I think it's important that we not misinterpret that to think that they are malingering or drug seeking or otherwise. And then there's the element of race. Systemic racial discrimination is a reality, and unfortunately, healthcare is no exception to this. And we're dealing with a disease that predominantly afflicts people of Black race. And so patients with sickle cell are very much subject to the biases, not only racial biases, but when you layer on that concerns about drug-seeking behavior, and the fact that they have been waiting long periods of time in severe pain, it's no wonder that patients with sickle cell have reported negative experiences in the emergency department. So I just want to bring that to light, to your attention, so that you can be aware of it, whether it be an implicit or an actual explicit bias, to be cognizant of it in your interactions with patients with sickle cell. Okay.
Yes, thank you. Good morning, everyone. I am going to talk to you from the patient perspective. I'm a mom of an adult. My son just turned 35 years old a couple of weeks ago. So I've been dealing with this disease for 35 years. So let me talk about the Sickle Cell Disease Association of Canada. Why do we have patient group? We have patient group because we need advocates. Every single time a sickle cell patient is seeking care, they will need sometimes somebody to speak for them, because most of the time they are not able to speak for themselves. Oh, sorry. So as Dr. Shelton just shared, sickle cell disease affects people from Africa, Caribbean, Middle East, and Central America, Southeast Asians, and Mediterranean. What does that mean? It means that it's people from visible minorities, racialized communities, and marginalized communities most of the time. And what it tells you is that in Canada specifically, we are left with supportive care. And what do I call supportive care is that if you have sickle cell disease in Canada, you have two options: hydroxyurea and blood. And that's not enough. One size fits all doesn't fit sickle cell disease because, as you know, it affects the entire body. It affects people in so many different ways that we normally will need a basket, of options to treat sickle cell disease. But we don't. So we rely also on the hematologist, oncologist, and the emergency department, because those crises takes you to the ER, either you like it or not. But I want you to know that when you see a sickle cell patient standing in front of you in the ER, it means that they are losing really hope, and they've tried every single thing that they know, that they've been trying, that their mothers have been on their knees praying, even the grandmothers, and they are just coming there to get relief for a very severe pain, and they are just desperate for relief. Oh. So, we've been talking about this, and we've been trying to support this community to see how can we best work together to have the best care possible. One of the biggest barriers for our community is that they've always reported the same thing, is the time. The time that they spend in the ER before the initiation of treatment and the assessment. We have a support group, and I just told them that I was coming to this conference, and I asked them, what should I tell them? What should I tell those physicians? And what came out is like, none of them has said that I received care under 30 minutes or within 30 minutes of me getting to the emergency department. They've reported hours of waiting time. And that's if I see the nurse, and by the time the physician gets there, I'm in tears, I'm crying, I'm desperate, and I really look like I'm begging for drugs. So unfortunately, that also is going to play against them. So we need to really work on that. We need, to work on the health-related stigma due to the race, as Dr. Shelton explained, and also the disease status, our socioeconomic status, Some of them said that I have to get dressed, I have to comb my hair, I have to look good so that, I don't look scary to them. And they will not be afraid of me and get close to me and give me the help that I need. So another thing also that they've reported is that when I'm in front of an ER physician usually, some of them do not know what I'm going through. I was looking at those numbers. The majority have reported that they don't really frequently treat sickle cell patients. That's normal because they don't show up to the ER because they use it as a last resort. So they should go now with the standards, the quality of standards that we get in Ontario. We are advising them, we are educating our community to telling them, go to the ER right away. Don't wait for a day or 2 or hours. Go right away and they will give you the care that you need. But for us to get that, we need to work together. And we need to be sure that you will give us the care that we need when we show up begging for help. So those people have reported that if you don't know about my disease, if you don't know, there are 2 ways you can do that. You can either look into my file or you can connect with my physician. And that has not been done. That's what the patient community has been reporting. And I'm a mom. I've been sitting from pediatric to adult in Canada, and I know that sometimes we have to make the call to the physician to say, we are going to the ER now. And that's why sometimes you see the sickle cell nurse rushing and coming and meeting us there, because we cannot afford to wait 2 or 3 hours to get the care that we need. So non-specialized staff, if they don't know, we want them to ask those who can tell them right away, because we need to be treated within those 30 minutes. So how do we do that together? I want you to look at those 2 pictures. That little boy, his name is Micah. When he goes to the ER with his family, he receives care right away because nobody wants to see a child suffer. Nobody wants to see a child in pain. And as he grows up, he's going to become the other one on the other side, and that's Alvin. That's a young man. And when he's going to show up in front of you, he's going to tell you, I've had hip replacement, shoulder replacement, liver failure. I was in a coma. And this is what I've done. This is my normal pain protocol, pain management, and this is what I'm asking for. And I'm sure you're not going to listen to him. But he's just telling you the truth. He's just making sure that you work as a team so that he can get the relief he needs. So health equity is needed. I will tell you something about sickle cell disease also, is that we don't even have a national registry for sickle cell disease in Canada. But other diseases like cystic fibrosis, with 3,000 patients have had one for 40 years. So how can we show the disease burden? How can we show the quality of the care? How can we report or where we live that we have to travel such a long distance to seek care when we know that the population affected do not live downtown? And all our physicians are downtown in every city that we go. So we have to remove those systemic barriers. We have to reduce the stigma around sickle cell by working together as a community, as Canadians, and so that we also are being treated as any other patient when we show up in the ER. So we are trying to build a community of strong allies. We are looking for people who will stand by our side and work with us, to do that. And how are we going to do that? It's by all of us recognizing the systemic health inequities that the sickle cell community faces in Canada. Understand your role and position of privilege when we're standing in front of you. Advocate for change by just, helping and asking for help when you need it yourself. We've said it, coordination between the ER physician and the primary care physician is essential for us. We want you to work together. We want you to reach out to them because they know their patients. And look at those medical records. They're right there. They will tell you if you don't believe, and believe the patient, because they've been living with their disease. We are not expert like you, but we are expert by experience because we're dealing with this disease. I look at my son now. I know when the crisis is coming. I see the sign. I look at his eyes. I look at the way he talks to me, the way he snaps sometimes because he's in pain, because he's tired. I can see when he's getting more and more, when the pain is increasing. And I know right away when we have to go to the ER. Last year, I saved his life, and I called the ambulance on time, and he needed to have surgery within 5 hours. So we understand that, we know that, because we've been dealing with it. So we want you to train and adopt the comprehensive care model, and all those practices that are here and they are available. And we want them to be non-Canadian for all Canadian physicians so that we can treat these people better. Because I have to tell you that physicians are telling us that, people are living longer with sickle cell disease. Yes, they're reaching the age of 50. When my son was born, I was handed a death sentence, but he's 35 years today. But let me tell you, there is no quality of life. Those people are tired all the time, the fatigue, and they can't hold a job, so they can't even have access to a higher education sometimes. So how can they just be happy and live like anybody else? So if they were receiving the best care possible, maybe that could be an option for them. So I hope everybody is going to listen to this today, and when you go back and you are in front, and we have a sickle cell patient in front of you, you will make sure that you remember those words and you look at that. And they've told me something. They said maybe representation matters for them. Maybe if people look like us, they will understand because they will be in the community. Personally, I don't believe in that. What I believe in is allyship for now. But I also I'm looking for a future where we don't need advocates and we don't need allies. Do you know why? That will mean that at that time we've achieved health equity in Canada because we will all be accomplices working together to better our community. That's what I'm looking for. Thank you for your time.
Thank you, Ms. Tinga. So briefly now, the second case is that of a 34-year-old female with sickle cell disease who presents with fever. She's had a 2-day history of fever, cough, shortness of breath, and chest pain. And on physical exam, she's febrile, tachycardic, tachypneic, soft blood pressures, hypoxic, tired looking. On chest exam, there's some decreased air entry and crackles in the right base. So the initial management is going to be supplemental oxygen, giving this patient some IV fluids, analgesia, again, important, so blood work and chest x-ray. And so what are you thinking here in terms of your differentials? I'll give you a few seconds just to think of this yourself in terms of what do you think some potential causes for this patient's presentation could be. So just to go through them here, so acute chest syndrome, which is a condition specific to patients with sickle cell, which we'll get into more. Could be a vaso-occlusive crisis, but certainly not only. It doesn't fully account for all the patient's presentation. Could be due to an infection, so pneumonia or a viral infection, or a pulmonary embolism. So the chest x-ray of this patient reveals the following. So there's an infiltrate in bilateral lung fields, more so in the right base. And so a polling question for you. So what would your next step be in the management of this patient? Would it be to order a CT pulmonary angiogram, to order IV antibiotics, to discharge the patient on oral antibiotics, or to consult for admission? So I'll give you a few seconds here. Okay, another 5 seconds. Okay. Okay, so about half for giving IV antibiotics and about a third for ordering a CT. So I think it's clear, 3% said oral antibiotics, but this patient needs to be admitted. I mean, they're hypoxic and unwell looking and abnormal chest x-ray involving. So there's reason for this patient to be admitted. Because this is a patient population that are relatively immunocompromised, they should be getting antibiotics early and therefore not waiting for the consultant to initiate the order for IV antibiotics. Although PE is in the differential, it's, the majority of the time and with this type of clinical presentation, it is going to be due to acute chest syndrome and so should be treated as such. And part of then the approach to looking for a PE would be if they're not improving, if there's a further progression in their course of illness despite the appropriate management. So not necessarily something that needs to be done, up front this early, and certainly not taking priority over starting IV antibiotics. So what is acute chest syndrome? So it has various clinical features. So first of all, it's a patient with sickle cell disease who has a fever and respiratory symptoms and signs, so shortness of breath and chest pain and cough, and then the signs of tachypneic and respiratory distress and hypoxia. And then a chest x-ray showing a new lung infiltrate. So I think it's important to realize, though, that a patient with acute chest syndrome may not display the entire clinical presentation. Their chest x-ray, frankly, may be normal at the early stages of their clinical disease. And so just keeping that in mind, that not necessarily everything is going to be there all at once. So it's the second most common reason for a patient with sickle cell to be hospitalized. And that's because it has the potential to cause mortality. There's a 5 to 10% fatality rate with acute chest syndrome. So acute chest syndrome is exactly that. It's a syndrome. So there are underlying reasons, causes, that lead to acute chest syndrome. And they include pneumonia, pulmonary infarct, so again, due to the occlusion, causing ischemia of pulmonary tissue, causing an infarction, or it could be due to a pulmonary embolism, either due to distant embolization, but also, importantly, could occur due to a thrombus occurring de novo. And then, importantly, fat embolization. So this is something that occurs because of the ischemia that occurs in the bone marrow. It leads to necrosis of the bone marrow and then subsequent embolization of the fat. And it also could be due to vaso-occlusion in the rib, causing atelectasis. So this emphasizes the point where if a patient who's having a vaso-occlusive crisis that involves the rib, by this patient getting early initiation of analgesia and preventing the splinting and the subsequent atelectasis, you could potentially prevent the complication of acute chest syndrome. All right? And so the management, it includes supportive management of oxygen, fluids, antibiotics, and analgesia, and some of these patients may require a transfusion. So a few pearls here about acute chest syndrome. Adults tend to get a greater disease severity and higher mortality rates, and that's because of the higher incidence of bone marrow necrosis and therefore fat embolization. So this embolization of the fat can occur to any organ. We're focusing here on the lungs, but because it can cause embolization and infarction of other distant tissues, it can lead to multi-organ failure, and this is where the mortality comes about with acute chest syndrome. So whenever you're considering that a sickle cell patient needs to have a blood transfusion, we need to be consulting our colleague hematologist. And just to emphasize, it is not a simple process to be ordering a blood transfusion in a patient with sickle cell. There are many factors that we need to consider that we don't normally consider with a non-sickle cell patient. And one of those is whether it's going to be a simple or an exchange transfusion. Last couple of a few pearls here about fever in patients with sickle cell, to take it seriously. So over time, sickle cell patients infarct their spleen, and so over time become functionally asplenic, and as a result become relatively immunocompromised. So any patient with sickle cell that has a fever needs a septic workup and should be empirically treated with antibiotics. And if there's no focus for infection, they should be treated with ceftriaxone if there's no contraindication. And have a low threshold for admission for these patients while waiting blood culture results to determine that they don't have any positive blood cultures or that they don't progress to become septic. Kids that are diagnosed with sickle cell are routinely put on penicillin prophylaxis because of the high risk of infection. And you should be aware that if a child develops a fever and they're on penicillin prophylaxis, that's not good enough treatment for the underlying reason for their fever. And that empiric parental antibiotics are recommended in patients with sickle cell disease and a fever, even in the presence of a viral infection. And again, to emphasize the importance of early initiation of antibiotics for this patient population, with the guidelines recommending within 60 minutes. Good, I gave her a full 20 minutes.
Good morning. So I've got case number 3, which is our last case for this morning. This is a patient very similar to the last one, in reference to Dr. Shelton's point about the potential complexity of transfusion. That's really part of the theme here. So this is a 33-year-old woman with sickle cell, hemoglobin SS genotype, who presents with pain in the lower back and chest, which is her typical sickle cell pain. She had an admission for acute chest syndrome and was discharged 2 weeks ago. Had been feeling back to baseline at home, and now is having progressive symptoms for 3 days. No other concerning symptoms and no clear precipitants. Of particular note, her hemoglobin is 57 and it had been 98 on discharge 2 weeks ago. The other blood counts are normal. And also of note, unconjugated bilirubin is elevated at 103. So we've got, I think, what's our last poll for the session here. What testing, in addition to the information we have, is essential at this point? So we have a patient who's presenting with pain crisis, whose hemoglobin has dropped substantially from when it was last tested at discharge. And probably I'll just say, similar to some of the other polls, there's no set right answer per se, but it's an opportunity for us to go through what's really essential and what's ancillary information. So let you finish up your survey response here, and we'll bring that up. So we've got reticulocyte count, blood smear, DAT, so direct antiglobulin test, group and screen, LDH, abdominal ultrasound. All right. So what testing is essential at this point? Group and screen. So really, again, kind of trick question. A lot of or all of these are going to be important aspects of the test. One of them in particular, and it's the third one down, reticulocyte count, because we're not quite sure why this person's hemoglobin has dropped so much, and that's going to be a crucial thing to know. If our reticulocyte count is way down, if it's very low, it's taking us in a thought process that maybe this person's bone marrow has stopped making red blood cells, such as something called an aplastic crisis. And that's going to be managed very differently than if the reticulocyte count is sky high, indicating that they're hemolyzing like crazy. So in the end, I'm actually going to show you the results of all of these tests, and we're going to put it all together. So reticulocyte count in this patient's case is 641, which is very high. Not completely unusual for someone with sickle cell, but indicating a very high rate of hemolysis at this point. The blood smear here, arguably isn't particularly helpful. Sickled cells, which are going to be present for this person at any point, whether they're well or unwell, you're always going to see sickled cells on someone with sickle cell disease blood smear, and polychromasia, which goes with the high reticulocyte count. DAT is useful to know. It's negative, so there's not kind of a sign of autoimmune hemolysis. I know we're getting into kind of specialized testing here from a hematology standpoint. Group and screen, so the antibody screen is negative, and the fact that we've now sent a group and screen, we can get the process going, thinking about whether we want to do a blood transfusion, but that's an important point also. LDH is sky high, 1,265, again going with the hemolysis, and abdominal ultrasound was done, nil acute, small calcified spleen, and I'm going to show you in a second why I'm thinking abdominal ultrasound in a patient with sickle cell whose hemoglobin has unexpectedly dropped. Sorry, there's one more quiz. What's the likely diagnosis? Occult bleeding, dilutional, hemolysis triggered by a febrile illness, aplastic crisis, splenic sequestration, or hyperhemolysis. I'll give you a second to respond to that. And then we'll bring up the slide. All right. What's the likely diagnosis? So excellent. We've got hemolysis in the lead here of the both causes. Hemolysis triggered by febrile illness taking the lead. Although I'm going to side with the folks in the 29% category that this is a fairly classic presentation of hyperhemolysis, which is very rare but potentially very life-threatening, and that's why we chose this to be one of the cases for today, highlighting and raising awareness, because emergency physicians are going to be the people who are first receiving this patient coming in with this life-threatening complication. Not splenic sequestration, because we've got a small shrunken spleen rather than a large engorged spleen that's kind of holding onto a lot of blood. Not aplastic crisis, because in aplastic crisis, the retic count would be low, indicating that the person's not making new red blood cells appropriately to respond to the hemolysis that someone with sickle cell will have at steady state. Could be occult bleeding, but it's not the best answer, and nobody chose it, and dilutional isn't on our, not top of our differential here. So what is hyperhemolysis? It's quite possible that there have been many people in this room who have never seen this, and for that you should be very grateful, because it can be scary and, again, life-threatening. This is where a patient has a post-transfusion hemoglobin that is lower than their pre-transfusion hemoglobin. You'll remember this patient several weeks back had received transfusions for an acute chest syndrome and had been discharged 2 weeks ago with a hemoglobin of 90, and now the hemoglobin's 57 with no other explanation. So what's happening here is, in addition to hemolysis of the transfused red blood cells, so they've basically mounted an immune response where they are destroying the transfused red blood cells, and in the process of this brisk immune response, their own intrinsic red blood cell breakdown is also ramped up, so you kind of get this effect. Classically onset within 1 to 3 weeks post-transfusion. It can be due to a new measurable alloantibody, so where somebody's actually developed a measurable immune response to a specific antigen on the blood that they received, but oftentimes that's not apparent. There can be an element of autoimmune, and as I've said a few times now, it can be potentially life-threatening. What is the big take-home point if you see this kind of a presentation? If hyperhemolysis is suspected, do not transfuse and call hematology. We don't want to be called about everything to do with necessarily someone coming in with sickle cell. This in particular, and why that is that further transfusions can actually dig you deeper. And this happened recently at my own center. You know, 1 bag of transfusion was given. The patient had come in with a hemoglobin in the high 50s, and it went down even lower after 1 unit was given. So I'm not going to spend much time on this. As Dr. Shelton had highlighted, there are specific extended antigen matching policies at most blood banks across Canada, and in fact increasingly around the world at baseline. And this is because of the risk of hyperhemolysis is one of the main reasons. So kind of stepping away from that harrowing case, I wanted to wrap things up with kind of bringing us back to the patient and the patient experience. This is a work of art by a talented artist who has since unfortunately left this world in the past couple of years. His name was Hertz Nazaire. He had lived with sickle cell disease, and he used his experience with sickle cell disease to try to communicate, and his skills as an artist to try to communicate what he had lived through to those around him. From what I've observed as a physician looking after patients with sickle cell and partnering with sickle cell communities and advocates in trying to bring about improvements in clinical care, has been that sickle cell is, the burden of sickle cell in someone's life can be like this enormous boulder that they're trying to push along. So the health challenges associated with that. Unfortunately, in addition to these health challenges, as has been highlighted by Dr. Shelton and really poignantly by Biba, patients unfortunately also then encounter, not always, but unfortunately with some regularity, a combination of health inequities and system barriers that make this burden even a heavier load for them. For that reason, there's ongoing work trying to reduce healthcare disparities in sickle cell disease. And here we're looking and speaking to kind of the Canadian experience, but also as we think about what's going on around the world, and really the burden of illness with sickle cell disease is most high in places like parts of West Africa, and really places where they don't even have as robust a healthcare system as we do. So always keeping that in the back of our minds and how we can advocate for global health equity. This is kind of old news now. This was an earlier iteration of what had been referred to earlier, the Ontario Quality Standards for Sickle Cell. In 2017, there was a precursor initiative where there was a clinical care pathway put together. Why I'm bringing this up, though, is not because of the clinical care pathway, but because woven through this document were comments from a session with patients and their loved ones, where they just shared little snippets of their experience from engaging with healthcare. And these are just little sound bites from what the people who participated in that focus group heard. Primarily about their experiences in emergency departments. So it's a fear of how you will be treated. I'm afraid I'll be sent home when I don't feel well. There's a visual disconnect. You're not bleeding or broken. ED's for emergencies. It is an emergency. That's why I'm here. Yes, I look this way, but you cannot see my pain. So as we think about that, we come to a venue like this, we're bringing together physician specialists like myself, emergency physicians, and patient advocates, and really thinking about ways in which we can partner together and empower patients and families to take an active role in their care, so that we have an informed, activated patient who can work in tandem with healthcare teams, both in the acute care setting and in the outpatient setting. This Ontario Health Initiative, the quality standards, just came out earlier this year, and it has 8 quality statements with a scope that really includes the whole life spectrum, and it applies to all care settings, both acute and outpatient. You'll see, and again, as has been mentioned earlier on, the importance of anti-racism in healthcare, and really each one of us, both systemically and individually, really trying to reflect on and try to mitigate and prevent any biases from affecting patient care. And so I think this is my/our last slide. And really what I'm encouraging each one of us here to do is to really dive into these patient encounters with empathy, understand what the patient's going through, all the other days, months, and years of their life other than those moments, those brief moments that they're there with us seeking that care. Joining in and helping to lighten that load by really providing excellent expert care, and as well kind of working together to decrease those health inequities and system barriers so that it's not such an uphill battle. And with that, I thank you, and we'll welcome your questions.
Thank you very much, and thank you all for attending the session today. It's been an invaluable experience from the 3 of you, Ms. Tinga, Dr. Vrostek, and Dr. Shelton. Thank you all. We will open the podium to questions. You can either submit the questions through the app, or you can certainly help yourselves to one of the mics over here. I will start off with some of the questions that have been posted online. So the first question to the panel is, in patients with sickle cell disease, is there an increased incidence or risk factor for having a PE?
Yep, so I'll be happy to take this one. So yes, absolutely. Unfortunately, there's some interesting data. I think the most recent set that I saw that was a large cohort was a lifetime incidence of pulmonary or of venous thromboembolism of about 30%. It's for a whole host of reasons. One, there's sickle cell itself is a prothrombotic state, but then as well, you think about some of the complications that they're having, needing to be in hospital, so the immobility. Sometimes there are things like orthopedic surgeries that were referenced in the presentation, and then as well, many of the patients will have central lines, so sometimes line-associated clots are some of those. So for a whole host of reasons, the risk of VTE is very high, and as a result, it wasn't part of the question, but as a result, many patients with sickle cell find themselves on lifelong anticoagulation because of the risk of further clots developing.
Great. The next question we have is, in general, is there anything we should be looking out for patients who are heterozygous? So as opposed to SS, they have SC or some other sort of phenotype with that.
Yeah. Did you want me to take that one too?
Yeah, that's
Okay,
right.
sure.
Go for it.
So was that heterozygous like sickle cell trait?
Sickle trait.
Trait. Yeah, it's a really interesting and sometimes, in a way, hot topic, more kind of from an epidemiologic research standpoint. I think from an emergency department lens, fortunately, there aren't many risks. What becomes interesting is if someone with sickle cell trait has been in these kind of unusual environmental extreme settings, so if you were doing emergency department care at a high altitude, so sometimes, in fact, someone with sickle cell trait, if they were to go mountain climbing or go into a high altitude setting, they can develop some of the same typical sickling complications, acute sickling complications, as someone with sickle cell disease. Similarly, if they get profoundly dehydrated or kind of like that overheated state. But thankfully, in normal environmental conditions, someone with sickle cell trait shouldn't get much in the way of acute complications. Aside from they are at kind of epidemiologically increased risk of hyphema, as well as renal papillary necrosis, and there's a kind of a small increased likelihood of pulmonary embolism. But again, it's more kind of on an epidemiologic level. Each individual person wouldn't be expected to have those complications at a high rate.
That's great, thank you. We'll take questions from the floor. Gentleman to my right over here.
Hi, I'm Raoul Daou. I'm from the University of Montreal. First, I've got two comments. First, thank you for addressing the stigma these patients endure, especially in centers like mine that don't see a lot of these patients, so they don't have a broken femur, and we really underestimate their pain. I've got comments on your analgesia protocols. You put everything subcute and IV in the same protocol, okay? And I understand why you give it every 30 minutes, because subcute could take up to 30 minutes to be absorbed. But intravenous is a lot faster. In fact, it's been shown in the safest way to give it is like 3 milligrams every 5 minutes IV, and that was associated with very few side effects, no desaturations. In fact, in my center, we give 5 milligrams every 5 minutes until your pain is tolerable. We did a QI, and we had no patients needing oxygen even with that protocol. So I think you should separate them at least if you want to keep the subcute, but as far as I'm concerned, subcute is not for us. Second comment is shifting from when you talk about naive patients, it's been shown that opioid receptors respond differently to different types of opioids. And if you change, the patient's been taking hydromorphone at home and you change the morphine, you should consider them, if you want to be safe, as naive patients. It's only if you keep the same opioids. And thank you again.
All right, thank you for the comment. Yeah, I think with regards to the dosing frequency, I agree in that more frequent reassessment of the patient in terms of whether their pain's under control and the need to give them more opioid analgesia. The reality is in the emergency department, I think it comes down to a staffing issue. So staffing, particularly nursing staffing, and monitoring, right? And as a result, comfort level with our colleagues to be able to give morphine, any opioid dosing that frequently. But I know that in my emergency department, it would really come down to the the availability of a nurse to be able to reassess the patient that often to determine need. And if they're getting it that often, most people would feel comfortable that they be monitored in a monitored setting too.
I think one of the other issues is getting access, like intravenous access, fairly quickly, whereas you can give a subcutaneous dose and then get the IV established as well. Like you said, it's a resource issue for getting that done quickly enough. I think we have another question there at the podium.
Hello, Sunil Yapati from McMaster University as well. Thanks very much for a useful talk. Picking up on Raul's points about the opioid analgesia, ASH 2020 has conditional recommendations around using IV ketamine as adjuncts for acute vaso-occlusive crises, and subsequent work since 2020 onwards, Middle Eastern trials specifically rather well done, are showing that IV ketamine is actually very useful and opioid sparing for acute vaso-occlusive crises. So comments, thoughts? Is it in this 2023 HQO standard, for example, as a possible alternative?
So
Right.
the question, I guess, relates to using ketamine as
for,
opioid sparing, because ketamine's been used in other painful
Correct, yeah.
situations.
So thanks for this. And I think it is important for us as emerge physicians to be aware that it is an option. And it wasn't included in this specific order set, but it is an option. But it's usually not going to be a first-line option. And I think but who knows, over time, maybe it will evolve to be more of a first line for this group of patients. But it really is going to be the patient that you're reaching high doses on opioids and they're not getting adequate pain relief, and you're starting to be concerned about that balance of side effects, particularly respiratory, CNS. And so as to be able to avoid the use of opioids, so the dissociative doses of ketamine. And so absolutely reasonable to use in this patient, but at this point, I think most people are not using it as first line though.
Well, thank you very much. It's certainly been a very informative session, and thank you all very much for coming in to present. Thank you all for coming. If I can remind you, please, to fill out the evaluations for this session this morning. It is certainly helpful for the CAPE committee in terms of feedback and improving for next year. So thank you all very much for being here this morning. Take care.